My job can best be described as problem solver. I'm there to help patients, their families, their friends, the doctors, the nurses, everyone in the hospital really, to solve problems, to figure out the right thing to do in a given situation in some really difficult situations. Sometimes it just takes giving some information, and sometimes it's about conflict resolution between the doctors and nurses, the doctors and the family, between the family. Sometimes people just need a shoulder to lean on, or they need a box of tissues, they need a good cry, they need a cup of coffee. They need support, and they need to be told when they're doing the right thing and even when they're doing the wrong thing. Sometimes they need coaching on how to have a difficult conversation. Imagine being someone's doctor for 20 or 30 years and maxed out on treatment, and now having to tell your beloved patient and their family that there's not much more you can do except keep them comfortable till their end time. It's really difficult. I often complain a little to my colleagues and friends that no one ever calls me when they're having a good ethics day. I would love to hear this. All of the patients at St. Thomas can make their own decisions, or most of them. The ones that can't have created perfect medical directives, living will, power of attorney, they're perfect. The ones that haven't, there is one special person in their circle of close friends and family that knows exactly what their wishes are, and everyone agrees with these patients. We just thought you'd like to know. I would so take that call. About 60 to 80% of the calls I get deal with end-of-life care. Everything from explaining what a living will is, to helping a family carry one out, to helping a family make a decision about how to take a loved one off life support when there really wasn't any instruction given at all. It's hard decision-making to do. It's hard to decide when that appropriate moment comes up. And despite all our knowledge that we're mortal, which I remember every morning when I get up, we all struggle so much with this part of our existence. A lot of my job is to just help people talk that through. I find that the end of our lives is just as profound as the beginning, and our ethical obligation as fellow humans is to help make that time as good as it can be. A good death, if there's such a thing. It is my sense that a death is the other side of the miracle of life. So let me tell you about some of the things people call me about, good stories and bad. I was called to our oncology unit not too long ago because a patient's son was refusing to carry out his dying mother's wishes, of which everyone knew exactly what she wanted. The case was complicated because he had mental illness, which was made worse by drinking, and so he would come to the inpatient unit at St. Thomas intoxicated, and the nurses were afraid of him, and the doctors were afraid of him, and the family was afraid of him. And they were afraid to negotiate with him about what the patient wanted. There really was not a lot that could be done beyond keeping her comfortable. It was exactly as one would expect for her diagnosis of widely metastatic cancer. But the family was reluctant to intervene because the situation was so difficult. And it was made worse because the patient's son was also caregiver to an intellectually impaired brother. So they were wondering what was going to happen there. So all these things are swirling around as they try to make a decision. What helped everyone, the medical team, the family, was finding the patient's medical directive in a desk drawer that had previously been locked. Her brother went there and found this. On the medical directive, this son was the power of attorney, and the brother was the alternate, and it had explicit instructions about what to do in this very situation. She had filled it out when she'd gotten her diagnosis. It allowed them the courage, if you will, to negotiate with him and to remind him what his mother wanted. When he was sober, he remembered, and he knew what was right. And it helped them help him to let her go. And so her wishes were carried out, and she was taken to hospice for her end time. Everyone was there at the end. One of my favorite memories is of a cross-covering physician. About this time, a number of years ago, his partner was on vacation, and he was now charged with the care of his partner's patients. And there was this lovely gentleman and his family. The patient had end-stage lung disease and was now ventilator dependent. There was no way to get him off the breathing machine, and in fact, his lungs were so bad that he had to be sedated, or he would constantly be feeling like he was suffocating. So the family said they knew this was not what he wanted, so they presented the living will, and the poor physician who didn't know the patient really felt conflicted about what to do because he didn't know the patient. And so that was the substance of the conversation. How do we make this decision? How do we match up the medical facts, the patient's wishes, and what the family tells us. As we made the plan later to take the patient off the breathing machine, we found the family on the floor of the hospital room with the Bible open, with the hymnal open, planning his funeral, making out wishes. And as his last heartbeat beat and the monitor line went flat, the daughter's cell phone rang, and it was his brother, who's an Episcopal priest in Virginia, calling to say, "I know that he's gone. He told me so. He told me everything's going to be okay." And so it was for them. But it's not just about paperwork. It's also about the conversation. I'm standing in our intensive care unit a few weeks ago, and this lady about my age comes in and says, "Could I talk to you? The nurses pointed you out to me. I have a problem." She said, "My parents never divorced, and my dad's going to cause trouble here." And I said, "Well, who's Frank?" Frank is the lovely man in the room with the patient who's critically ill in the ICU. She said, "Well, Frank is my mom's boyfriend." She turns 12 shades of red. I said, "Oh, okay, so what's the problem?" She said, "Well, my parents, when they split up a dozen years ago, never divorced. And my dad, when he finds out about this, is going to call up and want to make decisions just to spite her." She said, "I need to know what to do." Lucky for us in Tennessee, we actually have specific law that deals with this, that actually looks at the character of relationships and says, you know, it's not just about the legal relationship. So here we have someone who hasn't lived with this patient as husband for over a decade, and he is not going to make decisions both ethically and legally. Frank knew everything about the patient. He knew absolutely everything, and he eventually was the decision maker. So we were able to match up patient wishes, the Tennessee law, and what the family knew. And that patient walked out of our hospital. It's really hard to let go. Many of us think that the way to be a good daughter, a good son, a good husband, a good wife, a good partner is to do everything, even when everything won't work and might increase the patient's suffering. Life is a gift, and planning for the end of your life is too. I believe that we must do absolutely everything to help people live as well as they can for as long as they can. But when we can't, we have to do everything we can so that their leaving is filled with as much, if not more, dignity that they had here on earth, and maybe even more than that, less pain and less suffering.